Welcome to the second of the HDI's Spring Seminars seminar series. Today we'll be hearing from our panel of four who will speak from a variety of perspectives on the DSM-5 changes and implications. We'll begin with Ted Godlowski. He's a professor with UK Psychiatry and College of Social Work. And then we'll hear from Dr. Tom Prout, professor with UK School Psychology Program. I believe followed by Myra Beth Bundy. She's a professor of psychology at EKU and the Autism Certificate Program Coordinator. And then we'll hear from Christy Lieber, and she's a family therapist in private practice in LCSW here in Lexington, correct? We're very pleased to be co-hosting this event along with UK's Rehab Counseling Program and in conjunction with UK's College of Social Work, the Educational Counseling and School Psych Program, and also the Psychology Program at EKU. And just to go over a few details for today, we're coming to you live from HDI's Coldstream location here in Lexington. And obviously we have a variety of sites around the state that we're also being broadcast to live. Because we do this, we ask you to keep your microphones muted at all the other sites unless you're asking a question. And then we'll take the time at the end of each presenter's section to answer questions that you might have for them. And hopefully we'll also have a few minutes at the very end to cover some more general questions that you might come up with by then. We'll also be taking a 10-minute break at 2:40 for everyone to get up and stretch a little bit. So thank you.
Hi, I'm Ted Godlowski, and I'm going to be talking longest today, mainly about some of the general changes in the DSM-5, and also I want to touch on issues related to diagnosis for substance use disorders, since that is a significant change and no one else is going to talk about it, so I'll do it. Okay. First of all, because I teach psychopathology, I always like to make a few general comments about diagnostics before talking about something like the DSM-5. And whenever we are talking about diagnosis, we're basically struggling with problems of epistemology. Okay? How do we know what we know, and how do we know that what we know is true, basically, or real? I like to phrase this in terms of the problem of the three umpires, like baseball umpires. And the first umpire says, there are balls and there are strikes, and I call them the way they are. And that's kind of the position of radical realism. And if we apply that to diagnostics, it means that we actually believe that there are these specific mental disorders, that they are real entities in the real world, that they have real existence. Okay? The second umpire says, there are no balls and there are no strikes until I call them. And that's the position of kind of logical positivism. And again, applied to diagnostics, that would mean that these diagnostic categories that we use are simply mental constructs or social constructs, that they have no reality and no particular value in and of themselves. And the last is the third umpire that says, there are pitches that are balls and there are pitches that are strikes, and I call them as best I can. And that's the position of rational realism, and that's the position I advocate for my students, that diagnoses are somewhat arbitrary. They're groupings together of symptoms, and that they have a kind of secondary reality, because what we're really talking about is behavior, thoughts, affects, cognition, perception, and those are what is real. And the diagnoses are kind of like a kind of abstraction, one level beyond those, lumping them together into specific syndromes. And that although the lumping is somewhat arbitrary to a degree, it has real value. It has value in terms of indicating what are appropriate therapeutics in specific cases. It may have implications in terms of issues related to family history and genetics, and it certainly has implications in terms of research. So I think that whenever we talk about diagnosis, it's best to adopt the framework of rational realism, okay, as opposed to the other two. Now we also have, what we really diagnose are varieties of human suffering, basically. And we lump together specific signs and symptoms into syndromes. Unfortunately, unlike with physical medicine, we don't have any clear diagnostic markers for these things. There are no physical markers. There is no blood test you can take to determine whether someone has schizophrenia. You can't palpate someone's depression. Okay? And as a result, we have no real way of knowing that these syndromes are actually one thing, are actually a single entity, a single disorder. And we also have very little knowledge about where they come from. We have very little knowledge of etiology, and we only vaguely understand how best to treat them. The fact is that many, if not most, that many, if not most, individuals have more than one diagnosis, and we have to face the fact that perhaps the whole notion of comorbidity, of individuals having multiple diagnoses, and that being the fact probably more often than not, is as much the result of our diagnostic categories not being able to adequately embrace human suffering as it is the fact that individuals may actually have more than one disorder. Okay? So anyway, basically a problem of epistemology in terms of what exactly are these things that we call mental disorders. And we're fuzzy on that, we're vague on that, because we don't have the same kinds of guideposts that standard medical treatment has. Okay? There also is a problem between categorical and dimensional diagnosis. What we're used to in the DSMs, okay, from 1 through 4, is essentially a form of categorical diagnosis, that each disorder forms a category in and of itself that is more or less distinct from other categories. Categorical diagnosis serves good purpose where the members of a specific group look very much like each other and very different from other people. So, for example, if you look at the top bar in that in the graphic there on your screen, okay, if I asked one of you to come up and point to the exact point where white becomes black, you wouldn't have any difficulty doing that, because all the pixels on one side are far more similar to each other and quite different than the pixels on the other side, and there's a very clear delineation mark. Okay? The fact of the matter is, though, in much of diagnosis, our problems are not really categorical, they're dimensional. So, for example, if I were to ask you to go to that second bar, the one with the colors on it, and point to red or green or yellow, you could probably do it without too much trouble. But if I asked you to point to the exact point at which red becomes orange, or orange becomes yellow, or yellow becomes green, okay, it's much more difficult to do, because one tends to bleed into the other, and it's hard to tell where one ends and the other begins. And that's often the way it is with diagnosis. And as a matter of fact, in the DSM-4, interestingly enough, it was left out in the DSM-5, in the introduction, it talks about the fact that there is no certitude that one disorder is actually completely distinct from any other disorder, or for that matter, that disorders are in and of themselves distinct from some variant of normal. And so we have this difficulty. And it would be nice if we could use a more consistent and coherent dimensional approach. And the DSM-5 has tried to move in that direction. So we have in the DSM-5 for the first time a kind of touch of dimensionality. Okay? So for example, it allows certain specifiers to be used with certain diagnoses, okay? So you don't have to use a second diagnosis. So for example, major depressive disorder with panic, or persistent depressive disorder with anxious distress, okay? Recognizing the fact that there are many individuals who experience significant mood disorder, but also with very, very distinct and sometimes pretty graphic symptoms of anxiety. Okay? The DSM-5 also requires that clinicians rate severity of symptoms. In some cases, these symptom severities are rated by using some form of questionnaire or instrument. In other cases, it uses a kind of table that gives kind of paradigmatic descriptions of different levels of severity. And severity, I think much to the credit of the DSM-5, is based more on functionality than anything else. However, there are also diagnoses in which you simply count symptoms. So, for example, with substance use disorder, okay, if you have 2 to 3 symptoms, you're moderate. If you have 4 to 5 symptoms, or if you have 2 to 3, you're mild. If you have 4 to 5, you're moderate. And if you have 6 or more, you're severe, without any reference to how functional you are. And so we have this kind of, ambivalence about dimensionality, an attempt to move in that direction, but not fully or not totally. And I just wanted to show you just a couple of the instruments that are in the DSM-5. By the way, in the previous slide, right at the bottom, that website, the American Psychiatric Association website, is a place that you can go and actually take a look at and download and print off all the instruments for severity in the DSM-5. This is the DSM-5, what's called the cross-cutting measure, the main cross-cutting measure, step 1 cross-cutting measure. And it asks a series of questions that relate to broad areas of problems in human beings. You'll notice on the extreme left there are Roman numerals. Each of those relates to a specific kind or area of diagnosis. And then you have questions that are then answered not yes or no, but in terms of frequency of occurrence for these various things. This is what those Roman numerals stand for. So 1 is for depression, and 2 is for anger, and 3 is for mania, and so forth. So that when you, if you find that someone seems to display these kinds of symptoms, you can then move to what are called, at least in most instances, you can move to what are called step 2 measures, which then can give you a more precise read on whether or not the individual does have a problem in that area, and if so, how severe it might be. This is the second step level instrument for depression. It's 8 questions that are rated from 1 to 5, going from never to always. And so you can end up with a score of anywhere from 8 to 40 on this instrument. You can then go to this little scale here that helps you convert your raw score to a T-score. And if you have a T-score of less than 55, then chances are you're not depressed. If you have a score of from 55 to 59.9, you're mildly depressed. 60 to 69.9, you're moderately depressed, and 70 or over, you're severely depressed. This is the same thing, so I know many of you work with children and adolescents. This is the same measure of depression, but for 11 to 17-year-olds. Okay? So they have taken into account more than any of the other previous versions of the DSM the fact that children often display symptoms of disorder that are significantly different than those of adults. So they've tried to at least accommodate that to some degree. Okay? Now, in terms of sweeping changes in the DSM, first of all, you remember the multi-axial diagnostic system? Well, forget it. It doesn't exist anymore. Okay? There's no axis 1, 2, 3, 4, 5. Okay? Axis, what used to be axis 1, 2, and 3 have been collapsed into diagnosis. And diagnoses, whether they are of acute disorders or chronic lifelong disorders or medical disorders for that matter, are simply listed in order of emergence. So which particular disorder seems to be causing the individual greatest dysfunction, or which poses greatest risk to the individual. That you put first, and then you make your best guess about the rest of them after that. Okay? Axis 4, which used to be a place where you could put psychosocial problems. Instead of that, what the DSM is advocating is that we now use the V codes from the ICD-9, the International Categorization of Diseases, 9th edition, or the Z codes from the ICD-10. And as a matter of fact, in the DSM-5, those V codes and Z codes are listed in the 3rd section, okay, for handy use. And actually they are fairly comprehensive, okay, for the most part. Axis 5 is dropped, but there is a recommendation that we now use the WHODAS, the World Health Organization Disability Assessment Schedule, which is basically a measure, it's a structured questionnaire that attempts to measure the degree of disability or dysfunction that the individual may be experiencing as a result of whatever their symptoms are. Okay? The disorders have been kind of recategorized, and I'll show you those in a minute. The plan essentially tries to follow a kind of lifespan, first of all, beginning with the neurocognitive disorders that tend to be more prevalent or first show up in childhood, all the way up to the serious dementias and whatnot that tend to show up in later life and everything in between. Also, the diagnoses have been ordered in terms of first looking at those that have internalizing symptoms like depression, okay, and then those that have externalizing symptoms like impulsive behavior. Okay. Also, you may remember the NOS, not otherwise specified, which was part of every diagnosis. That no longer exists. We now have other specified and other unspecified diagnosis under each specific category. And the preference is that you would use other specified. And when you use that, what you're specifying is the symptoms that you're observing. Okay? So for example, you might have someone with symptoms related to trauma, but whose symptoms do not meet criteria for post-traumatic stress disorder. You can diagnose them as other traumatic disorders specified, and then you list the symptoms that you observe. So that's kind of, I kind of like that, because some of the work I do is with trauma, and it allows us basically to dignify people who are suffering as a result of trauma with a diagnosis, which we didn't have before. If they didn't meet criteria for post-traumatic stress disorder, which is a very high bar, okay, there was no diagnosis that you could use. So now we have a kind of other specified kind of diagnosis. This is the WHODAS. I'm not going to go through it at any great length. I just want to point out to you that it's arranged in terms of domains. So the first domain looks at cognition. How's the individual thinking? How's their memory? Mobility. How well can they get around? How much are they inhibited in getting around as a result of their symptoms or disorder? Self-care. How well can they take care of themselves? Getting along with other people, so kind of social interaction with other people. Okay? And then life activities, which breaks into two separate domains, those activities that are done around the house and those activities that are done in school or at work. Okay? And finally, participation. So how do symptoms affect the individual's ability not only to relate to other people, but to relate to their own family, to participate in their own community, to basically be a social being, fundamentally, a participating social being in their own community. Okay? Now, I'll run through these disorders very, very rapidly. I'm not going to mention many of them except to indicate where there might be some new diagnoses. We have, first of all, the neurodevelopmental disorders. Intellectual disabilities have to do with people that have problems with intellectual functioning, basically, mainly beginning in childhood. And one of the nice things, I think, about this diagnosis is that the emphasis is not on IQ, it's on functionality. So individuals may have an IQ 70 or below, but they are functioning very well, and therefore you don't necessarily use this diagnosis with them. Other individuals may have IQs above 70, but are doing very badly, and you might want to use this diagnosis with them. So the emphasis is away from IQ testing and onto functionality. Then communication disorder, autism spectrum disorder, which you'll hear more about in a bit. Attention deficit hyperactivity disorder. The bar has been lowered for that a little bit, and it has been lowered even more when we're talking about adolescents and adults. So we should plan on seeing more individuals with a diagnosis of attentional deficit disorder. Okay? And then specific learning disorders and motor disorders. Okay? Schizophrenia spectrum and other disorders, that pretty much remains much the same as it is. There have been some changes in the diagnosis for schizophrenia. So the notion that if the delusions were bizarre enough, that's all that you needed is no longer there. Or if you hear more than one voice talking to each other, that special, those are Schneiderian, first level hallucinations, that you no longer give that any special consideration. Okay? Catatonia is now its own disorder, which is new, and catatonia can also be used as a qualifier for any psychotic disorder. Okay? Then bipolar disorders remain pretty much the same. Depressive disorders, we have here a new diagnosis, which I think is an attempt to try to move practitioners away from giving children and adolescents diagnoses of bipolar disorder, bipolar 1 disorder. It's disruptive mood dysregulation disorder. Okay? And then the rest remain pretty much as is. Persistent depressive disorder is what we used to call dysthymia, and also major depressive disorder that lasts longer than 2 years. The obsessive compulsive disorders are pretty much unchanged. However, there is the addition now of hoarding disorder. So you can, and I'm not going to go through the criteria for that, but it used to be simply a possible secondary symptom of certain disorders. Now it's its own disorder. And there is a nice little, it's not in the diagnosis itself, but in the text for the diagnosis, it also indicates that this often occurs not only with objects, but with animals. And we see that regularly, don't we, in Kentucky, that we have somebody that has 24 horses they can't feed or take care of, or 200 dogs, or 50 cats, or something like that. Okay, probably what we're seeing here are manifestations of a kind of hoarding disorder. Okay. Trauma and stress-related disorders. Reactive attachment disorder has been broken into two diagnoses. First, reactive attachment disorder, which is the same as it was, and disinhibited social engagement disorder. So reactive attachment disorder for individuals who can't form attachments or have great difficulty forming attachments to anybody. Disinhibited social engagement disorder for individuals who too readily form attachments to people, who too easily form attachments to people. Okay. Post-traumatic stress disorder, we now have criteria both for individuals over the age of 6 and under the age of 6. So, again, a recognition that children experience trauma somewhat differently than adults do. Dissociative disorders are still there. I'm not quite sure why. I don't think I've ever seen a case, but anyway, they're still there and they're pretty much unchanged. Somatic symptom and related disorder. Somatic symptom disorder is a new diagnosis. Careful of this. It only requires one symptom. And it is, at least in my mind, almost impossible to distinguish from someone that has a serious symptom or a serious illness and is quite preoccupied about it. Okay? So it's very hard to distinguish between somatic symptom disorder and a variant of normal. I mean, if I had a heart attack, I'd be pretty concerned about what my heart was doing for a while. Okay? That doesn't necessarily mean I have a mental disorder. But, I probably would meet criteria for this disorder. Feeding disorders, pretty much as they have been. Elimination disorders, as they have been. Sleep-wake disorders, pretty much the same. Interestingly enough, breathing-related sleep disorders, which are actually not psychiatric disorders. They're actually not mental disorders. They're purely physical disorders, although they may have some emotional sequelae, are listed here. Sexual dysfunction, pretty much the same as they have been. Gender dysphoria is a new category of disorder here, so we have gender dysphoria in children and gender dysphoria in adolescents and adults. Okay. Disruptive impulsive control disorders, pretty much the same as they have been. And substance-related disorders, which I just wanted to dwell on for just a little bit because that's my specialty area. First of all, for substance use disorders, there is no distinction anymore between dependence and abuse. It's only one disorder, substance use disorder. Okay? What happened is they took the four criteria for, the seven criteria for dependence, if you remember from the DSM-5, and merged them with three of the four criteria for abuse. They eliminated the criteria that has to do with legal problems, which I frankly don't mind, because whether or not someone has legal problems because of their use of a substance may have more to do with how diligently the police enforce the law in a particular community than with how severe their problem actually is. And then they added a criteria for compulsive use to bring it more in line with the ICD-10, I think. Okay? We have some new diagnoses. We have a behavioral addiction diagnosis for gambling disorder. And there are some people who have real problems with that, because once you start talking about behavioral addictions, where do you end? I mean, virtually anything human beings like to do and do often and may occasionally cause them a little trouble, I guess we could use the label of addiction for it. Okay? Cannabis withdrawal is a new diagnosis. Okay? Caffeine withdrawal is also a new diagnosis, even though there is no diagnosis for caffeine use disorder. Okay? In the DSM-4, let me go back. The DSM-3 had separate criteria for substance use problems by drug. So there was a separate criteria for alcohol dependence and alcohol abuse, for cocaine dependence and cocaine abuse, for opiate dependence, opiate abuse. In the DSM-4, we got rid of that because we thought there was one single underlying addictive process, and so we had unitary criteria for substance use disorder, for substance dependence and substance abuse, even though the diagnosis remained drug specific. In the DSM-5, we've gone back to having separate criteria by each drug category for diagnosis, and I don't have the faintest idea why that's done or why that's been done. Okay, but it's been done. I already mentioned the specifiers, and what used to be a qualifier for partial remission is no longer there. So now remission is like pregnancy, either you are or you aren't. Okay? Either in remission or you're not. You can't be in partial remission anymore. Okay? I just wanted to, these are the criteria for cannabis withdrawal. They indicate three or more of the following symptoms: irritability, anger or aggression, nervousness or anxiety, sleep difficulty, decreased appetite or weight loss, restlessness, depressed mood, and at least one of the one of the following symptoms that causes significant discomfort, like abdominal pain, shakiness, tremors, sweating, fever, chills, or headache. Okay, I treated probably a couple thousand people with substance use disorder and have never seen marijuana withdrawal. But I'm told that there are some animal experiments that indicate that it does exist. So it's not a terribly well-researched thing, but it's there. When I look at these criteria, I probably could provoke these criteria in most of you by taking away your cell phone. What I've done is I've taken the criteria and reduced them down again to a single set of criteria with blanks for the drug, So criteria, the overall kind of mantra that begins it is that substance use disorder is a problematic pattern of the use of some kind of substance leading to a clinically significant impairment or distress as manifested by at least 2. So now you only need 2 out of 11 instead of 3 out of 7 for the diagnosis, occurring within a 12-month period of time. The drug is often taken in larger amounts or over a longer period than was intended, which indicates a loss of volitional control. There is a persistent desire or unsuccessful efforts to cut down or control whatever the substance's use. And again, the underlying concept here is one of a loss of volitional control. A great deal of time is spent in activities necessary to obtain whatever the substance is, use it, or recover from its effects. And the notion here is that over time, the substance use gains great centrality, importance in the life of the individual. Okay? And time being a measure of importance, we use time. We only have so much time. We spend more time on one thing, we have less time for other things. And how we spend our time is largely a measure of what's important to us. Craving or strong desire or urge to use, this is a new criteria, okay? And it has to do with basically a physiologic response to anything that indicates the presence of the substance. We have some good knowledge about the exact biology that underlies craving. It has to do with changes that occur in the neurons in the nucleus accumbens, changes that are a result of a protein called delta phos B. And so, you know, I'm okay with craving being added. Recurrent substance use despite resulting in failure to fulfill major role obligations at work, home, or school. This was formerly an abuse criteria, now the dependency criteria. Can be hard to apply to certain groups of people. You know, I mean, failure is easy to measure if you've had previous success. So you have someone who's been successful meeting their major role obligations, now they're using a substance and they're failing to meet major role obligations. You can pretty safely say it's probably because of the substance use. What do you do for somebody who's never met major role obligations and now they're using? Okay? Is it that is their substance interfering with their ability to do that, or are they just bad at life? Okay? So it's hard to apply to some groups of individuals. Continued substance use despite having persistent or recurrent social or interpersonal problems caused or worsened by the effect of the substance. This again is a former abuse criteria. Important social, occupational, or recreational activities given up or reduced because of substance use. And again, this is because of the importance, the centrality that the substance use gains in the life of the individual. Okay? 8, recurrent use in situations that are physically hazardous. So being under the influence when you're doing something where you might harm yourself or someone else. Substance use that is continued despite knowledge of having persistent or recurrent physical or psychological problems that have likely been caused or worsened by the use of the substance. This is one of the most abused of all the criteria. It's not about simply having a physical or psychological problem caused or worsened by the substance. It's knowing that you do and continuing to use. And again, it's an extension of that notion of the centrality of the substance abuse. So the individual is willing to risk their health, their sanity, and even their life in order to continue to use. 10, tolerance, which is exactly as it was in the previous criteria, and 11, withdrawal, okay, exactly as it was in the previous criteria. I'm running short on time here, so I'm going to, when you print this out, you can take a look at this case of a 34-year-old heavy marijuana user, okay, and what I've done is I've highlighted the symptoms. And even though this guy looks like a train wreck, I mean, he's not working, he dropped out of school, lost his girlfriend, has no friends, has no job prospects, given our current diagnostic scheme, he would be marijuana use disorder moderate, okay? Because he meets 5 rather than 6 criteria. Okay? We now have a new disorder, gambling disorder, which is again a behavioral addiction disorder. It is modeled to some degree after the substance use kind of disorder. So the need to gamble with increasing amounts of money in order to achieve desired level of excitement. Restless or irritable when attempts to cut down or stop gambling. Has made repeated unsuccessful efforts to stop gambling. Is often preoccupied with gambling. Often gambles when feeling distressed after losing money. Often returns the next day to get even. Lies to conceal the extent of gambling. Has jeopardized or lost significant relationships, a job, or education, or career opportunities because of gambling, and relies on others to provide money to relieve desperate financial situations caused by gambling. So very much kind of parallel to our other substance use diagnoses. Okay? Then we have the neurocognitive disorders, which I'm not going to run through. And again, these neurocognitive disorders are all basically medical kinds of issues, different forms of dementia, fundamentally. Personality disorders, they've gone back to personality disorders are kind of interesting. First of all, they're using the old cluster A, B, and C kind of nomenclature, which was kind of passing out of existence. They kind of revitalized it. I'm not quite sure why. Okay. There are two ways in which you can diagnose personality disorder. One is the DSM-5 method, no different, exactly the same criteria. The other is a rather complex use of a basically 5-factor model of personality as a way of diagnosing personality disorder. You can't use it for all personality disorders, but you can use it for most of them. And it requires very careful attention to very specific kinds of dysfunction in identity, in interpersonal activity, and various kinds of personality functions. Okay, and you don't have to use it. It's located in the back section, the third section of the DSM-5, but it's their bow to functionality. I know a fellow that was on the expert panel for personality disorders who was very upset because they worked out a much better schema which the APA decided to ignore. And so they created something that's neither fish nor fowl in terms of personality disorders. Then the paraphilic disorders and other conditions that might be the focus of some kind of clinical attention. Okay? And that's it for me. So does anybody have any questions? Did I do okay on time? Okay.
Can I ask a question?
Yes, of course.
I read this somewhere, maybe in the DSM. Is there a video, some kind of gaming disorder that's being monitored?
No. There was some discussion about including internet addiction or internet dependence disorder or whatever they were going to call it.
But it didn't make it in.
No, it didn't make it in. And again, this is one of those things that, once you start talking about behavioral dependencies, where do you draw the line? Okay? And so I would expect that we would see more of that rather than less of that. Okay? Anything else? Well, if not, we'll move on to the next presenter here. We're going to switch places here.
My name is Tom Prout, and I am primarily have been with the school psych program at University of Kentucky, but I've also been affiliated with HDI for a number of years. And just a little bit in terms of way of background and how I look at this. One is I've taught courses for years where I've used various versions of DSM. Always required of my students because I think it's something good or bad, it's something you need to know about. I've worked in the area of intellectual disabilities for years, almost my entire career. But one of the things I'm going to bring a little bit of perspective to this. On a part-time basis over the last 20-some years, I've been a consultant for Social Security Disability. And what I do in that role, and I'm sure many of you have filled out forms, gotten requests from disability, I'm one of the folks that sits in Frankfurt and reviews all your reports. I did this in the state of Florida. And one of the things that this has done is over the last 20 years, I have probably reviewed somewhere over 100,000 different kinds of reports, from the reports that disability purchases that are called CEs. I notice we've got a couple community mental health centers online, outpatient records, inpatient records, school records. So I've seen everything in terms of different reports. And one of the things that this has allowed me to do over the last year is to take a look to see how we're transitioning, and if we are transitioning, from DSM-4 to DSM-5. Now, two issues I'm going to cover. One is just some general issues on DSM in general, including some of the critiques that have come out since it was introduced. I think it was in May when it came out. You probably will notice a few things that I'll have some opinion on. So I'll try to label what's my opinion and what I've seen. But one of the things, again, that I think I've got a fairly good pulse on in the work that I do with Social Security, in terms of what's going on in terms of practice and how this is being used. Okay, now as I look around, at least the folks that are here, I'm not sure how many of you remember DSM-2. Now, when I started in the field, we used DSM-2. And let me give you a little facts on DSM-2. You really can't tell from the size here, but this is about a 5x8 booklet. And I almost have to call it a booklet. It was originally 134 pages. Now we are at, I feel like I should be at church. Open your hymnals too now. We are at over almost 950 pages in DSM-5. DSM-2, as I said, was 134 pages. The diagnostic section that covered all the diagnoses was 38 pages. Now, there's a lot of critique with DSM-2. There were a lot of things that were written on. It was a lot easier to use. Now, I had a good friend when people were still using DSM-2, was a clinical social worker in a community mental health center. And my friend's name was JT. And I said, well, JT, how do you use DSM-2? And what he would do is he would take DSM-2 with his clients, sitting across the table, give them DSM-2, say, thumb through that and see if there's anything you like. Now, ethics, good practice, I don't know. It was interesting. The clients at the time were very close in picking out diagnoses, and this is not a research study, but we're very close in picking out the diagnoses that the teams came up with. Now, think of taking this, sitting across from a client, say, take this home and read this week and see if there's anything you like. Now, I can't imagine doing it. A lot of critiques with DSM-2, but having said that, when DSM-3 came out, which was, I think, probably about half this size, it was this mammoth expansion of DSM-2. Okay. When DSM came out in, I believe the publication date is May of 2013. If you follow any of the critiques that were in some of the psychiatric newsletters, this is more thought pieces than research. It was not a happy beginning for DSM-5. There was a ton of critique. DSM-5 was 14 years in development. And I see a couple of my students here, and I'm not sure when you took the course from me, but right around 2004, 2005, I'd say, look, I'm sorry I'm making you buy DSM-4 because the new one is going to be out next year. So 2006, I said, I'm sorry, I'm making you buy this. Well, it is now, it was 14 years later that it came out. Now, one of the things that I've seen in practice are a couple things, and I'll talk about some of them in a little bit more detail. I would say probably half to 2/3, and this is a guess, I'm not counting them at my desk, folks are not using DSM-5 yet. They're still using the multi-axial system. A lot of people still like the GAF, which stands for Global Assessment of Functioning. I used to call it the Guess About Functioning. And I think a lot of people have felt uncomfortable collapsing into the single axial system. And I'll talk a little bit more about that in a bit. Some of the critiques that came out, and I was interested in what you said to the person who was on the personality disorder. There was a lot of critique, and some of this is gossip. You know, it's not necessarily anything that people have solid foundation of. But one is that the task forces tended to ignore a lot of input from a lot of sources, and that the task forces themselves were a lot less inclusive of other disciplines, even though if you look in the back, there's a lot of the social workers, psychologists were involved in the field trials, but it seems to have a much more psychiatric and medical input than previous editions. And again, I would tend to agree with that, but I've also seen that written in a lot of places. The non-axial or single-axis reporting, as I said, a lot of people haven't transitioned with that. And basically what we've got, instead of the 5 axes, we've got the 4, or all collapsed into one. Now, in terms of practice things, a couple things I've seen, because the people who have been using DSM-5, they're also loading all of what used to be on axis 3, or the medical conditions, onto axis 1. And it strikes me as an awful lot of lumping. And from a practice standpoint, I saw a report the other day where their person had gone to an evaluation, there were 1 or 2 psychiatric diagnoses, and it listed over 15 medical conditions. And I think one of the things we have to be careful on, as not being a physician, is make sure that where that information is coming from. Because if you list it on a report and you say this person has some sort of lung condition, and you sign the report, it's as if you're diagnosing it. Now, what I always advise people to do is, if you're going to list the medical conditions, either make sure it's clear in your report where that came from, or when you're doing your listing, by patient report, by other medical records, etc. And I think potentially, if you're not careful in labeling that, they say, well, Dr. Prout, you're a psychologist, and you just diagnosed this person's cancer. And I go, well, it's a little side skill I have. Okay, it's not. So you've got to be very clear in the specification of that. As Ted mentioned, there's been a lot of increase in the subtypes, specifiers, severity labeling. It is a much, much more detailed diagnostic procedure. And there's been a lot of criticism that it's been relatively imprecise in terms of some of the differences and whether they are real differences. Most diagnoses are made with probably a half an hour to an hour mental status exam and clinical interview. Okay. Can you sort through 900 pages and get all the information with that? Now, some of the instruments that Ted mentioned, I think, have some potential use. I haven't seen any of them used, reported, or very few. Let me not say any. So we haven't made that transition yet to using, I think, some of those instruments. There are some structured clinical interview formats. The one I'm most familiar with is the SCID, which is about an hour and a half, tied to DSM-4, and it's cumbersome at best. But again, I don't see that being used very frequently. Okay, an issue of reliability in diagnosis. We know, and I've looked at a little bit of the field trials and some of the current literature. We do know from the literature in general is that we're pretty good at making diagnostic differences between things like mood disorders and psychoses, the broader categories. As we get more specific with severity, subtypes, specifiers, the reliability drops like a rock. So pretty good with the general areas. The more specific we get, the reliability goes down. What have we done with DSM-5? We've added a whole lot of specification. Now, I do like some of the things, like you mentioned, with the major depression, with panic. We know that the internalizing disorders are often hard to separate out. And, one of the things I've seen again, from practice is I've seen people with 10 or more different diagnoses within a year by going to different agencies, et cetera. We also know that diagnoses are more reliable with severe disorders versus the milder disorders. And again, when we look at people with mild depression, anxiety, mild, moderate, it's pretty hard to sort that out. Whoops. I do miss my DSM-2. Okay. Some of the other critiques. With some of the, and you mentioned they've lowered the bar in some of the areas, and I think there has been some criticism that with the changing of some of the standards that we have made some things that have typically been generally within normal limits as now fitting into a cognitive or into a diagnostic category. The one where I've seen some things written about are mild neurocognitive disorder. Often, as people age, memory goes. I probably won't be able to find my keys when I leave here, okay? Do I have mild neurocognitive disorder? Ask my wife, she might have a better idea, but no, I don't think so. But there's been some critique of that in terms of that we're making things that are typically just normal developmental processes into clinical areas. There are some of the newer disorders. Disruptive mood dysregulation disorder. I think there's good aspects of that and some less than good, I'll put it that way. The good is that I do think that it will probably reduce the number of kids who are diagnosed with bipolar disorder. There's been quite a bit written on the overdiagnosing of kids with bipolar disorder. Now, for those who've been in the field for a while, it was about 15, 16, 17 years ago, there was a book came out that was a little bit of a popular press, but one that a lot of professionals read, called The Bipolar Child. When that came out, diagnoses of kids with bipolar skyrocketed, okay? And in my opinion, probably inappropriate. So I think the good thing is that we've got one that is probably a better descriptor. What we don't know is that this diagnosis sort of came out of nowhere. Very little research on it, and we don't know whether there's a scientific basis of it. And lastly, I'll hit on critiques. Again, with the way some of the panels have been handled, what is the scientific basis of a lot of these different descriptors? A lot of it is I talk to people who know some of the workings of the various task forces over the years on the different disorders. And I know in particular when DSM-3 came out, which is the first major revision, it was basically a committee. the task force would sit around and somebody would say, I like to nominate that we have, of these 9 criteria, 4 would make the diagnoses. So they'd vote on it. Somebody would say 5, okay? Really not that haphazard, but again, the real scientific basis is not real clear. Okay. Okay, changes in intellectual disabilities. The American Association of Intellectual and Developmental Disabilities several years ago put out their diagnostic manual where they changed the term of intellectual disability. Unfortunately, that did not catch on. It probably did in facilities and institutions that were primarily for folks with intellectual disabilities. But in terms of the general practice, community mental health centers, et cetera, the term intellectual disabilities did not really catch on. One of the positive things I think about the change, there's been quite a bit particularly in the intellectual disability area, about the pejorative use of the word retard. Okay? Walk down any middle school between classes, and chances are you're going to hear that word. Okay? It's really become a pejorative descriptor in our society. Then I was thinking back, and if you go back to the original diagnostic system that the Intellectual Disability Association put forth, it was imbecile, idiot, moron. Those are all parts of our language. So I'm hopeful that with the use of this term, that eventually the pejorative, particularly the term retard, is going to diminish. My guess is it's not going to disappear from our everyday language. And I've talked with several people, and we've wondered, well, how could they take the term intellectual disability and turn it into a pejorative? What would be a shorthand for them? Hopefully, we won't go down that road. The other part of the term is in the category. It says intellectual disability. Then underneath it says intellectual developmental disability. Okay. Probably a bit of semantics, but when you look at the federal definition for developmental disabilities, it encompasses intellectual disability, but it's a much broader term. So there's been some folks who have questioned whether that is something that ought to be in there in terms of maybe confusing things. We've already talked. There's no longer Axis 2. The definition depends on 3 domains: conceptual, which is basically the intellectual part of it, social, and practical. And it uses descriptors for mild, moderate, severe, and profound. And if you look in this little book, there's about 3 pages where they say, here's what mild looks like in the conceptual domain, the social domain, and the practical domain. And it's about probably a table that's about 2 or 3 pages. And that's where the diagnoses of mild, moderate, severe, and profound are going to be based. Okay. It decreased the emphasis on IQ. The IQs are no longer associated by mild, moderate, and severe, and profound, but part of the definition is that there has to be an IQ of basically 75 or below. They say 65 to 75 and below as a range. Okay, but there's no longer moderate is 40 to 55 or anything like that. They've also added a diagnosis called global developmental delay, very briefly described in there. But what this is really designed to do is to put a label on those kids who appear to have an intellectual disability prior to age 5, but we're uncomfortable in really labeling it as an intellectual disability, or previously to that with mental retardation. For those who have done testing with kids, the research and our clinical experience, we know that getting an IQ on a 3.5-year-old is not necessarily predictive of later development. Okay. Now, as was mentioned, and is that the definition has moved more toward assessment of functional abilities, okay, or adaptive behavior. And I want to throw some cautions in with this, and I'll give you a couple examples later on in terms of where I think this comes into play. One is there are other reasons for adaptive deficits other than the intellectual disability. Okay, I've done a lot of work and done quite a bit of research in the area of dual diagnosis. Okay. Let me give you just a hypothetical case. We have someone with, let's say, an IQ in the 60s, major depression. They're immobilized, we look at function, and we label them, even though we've got an IQ in the 60s, with adaptive behavior in the severe range. Now, one of the things we all know that a lot of times in our records, labels stay for a long time. And a lot of times, I've seen it, and this isn't a critique, in community mental health records, where somebody has an initial diagnosis and a GAF, and it never really gets changed. It stays on there. Okay, so I've got my individual with an IQ in the 60s, but adaptive behavior in the severe range. Okay, now, first, being interested in dual diagnosis, when I see that kind of gap, that raises my dual diagnosis antenna, that there's something else that's going on. But we take this individual, they've got major depression, but we find a medication or therapy or whatever that works, and all of a sudden their function comes back. Okay, so were they really intellectual disability severe? Or was it the dual diagnosis that was pushing that down? And does that get changed? So we've got to keep the idea of comorbidity there. What about language disorders? Individuals with a discrete language disorder, and we look at the social domain. That's going to be different. Health status. We know, again, and there's some research in the intellectual disability area, that when people with intellectual disabilities have chronic health conditions, their adaptive behavior is diminished. With physical impairments, that can change, particularly things like mobility, community access, and interaction. Okay, so there can be other reasons for the adaptive measures being low, or our functional assessment. The second thing is informant variance. Okay. I know we've got a couple people who work in the schools here. Just for the group here, any others that work in the schools? Okay. One of the things I've seen is with adaptive measures, and good practice would say, get a parent, one or two teachers, etc. Okay? And I have seen adaptive scores be 50, 60 points difference based on informant. There's some research to suggest that some of the variance in our informant measures, including behavior rating scales for typically developing folks, is related more to what's going on with the informant than necessarily the individual that they are providing the information on. So we may have some unreliable informants. We have situational variance, home versus school. And again, for those who work with kids, you've seen things where you talk to the school, and the kid is fine. You talk to home, kid's terrible, vice versa. Okay? I remember a case very early in my career, came into a clinical setting, and this kid was all over the place. Nobody could control him. We couldn't do valid assessments. It was just terrible, terrible, terrible behavior. So we decided we better go out and do a school visit on this kid. So we go up to the school, and I'm looking around, and at first I can't find the kid. And he was perfectly behaved in school. Matter of fact, there were 2 or 3, if I was going in sort of blindly and said, well, the 2 or 3 kids that seem to have problems, this kid wouldn't have been one of them. So we see that kind of variance. Second kind of variance we see with kids is, with raters, is special ed teachers versus regular ed teachers. One of the things I've always liked, and I'll say for our UK folks here, that I've always liked positively about the special ed program at the University of Kentucky is that the folks going through the teacher ed program there have a very positive view of promoting positive characteristics, attributes of the kids they work with. And so, but they're also getting a different perspective. A regular education teacher may have a kid who's causing difficulty who might be just the middle of the pack in a special ed. And again, this gets into, I've got it in the next line in terms of the bias, both positive and negative. Sometimes there's almost wishful thinking that somebody functions better in these things, or there may be some secondary gain for reporting the adaptive behavior lower. Context, urban versus rural. Okay. Adaptive behavior for a kid in Louisville, particularly in some of those community and practical things, may be much different from a kid from a small rural town. So adaptive behavior, and I like the idea on the assessment of function and adaptive, but it can be sort of an elusive term. There's a lot of variance in there. Okay, another thing in terms of the diagnoses is that they've essentially eliminated borderline intellectual functioning. And it's listed under, there's been some critiques of the editing or lack of editing in this. When you find borderline intellectual functioning, as I was preparing for this, I said, well, I want to go see what's written in that. It took me half an hour to find where it was. It's not in the index, and it's this page 720, say this little paragraph as a V code, and for some reason they've got it listed under a heading of non-adherence to medical treatment. It looks like an editing error, but I don't understand that. And I'll come back to borderline in a second. One of the things I've seen with the practice issues, particularly in not really having borderline intellectual functioning as at least an apparent option, is I've seen 3 cases recently with individuals with IQs above 70, one who had IQs in the 80s that were labeled either mild, moderate, or moderate intellectual disability. And my guess is these are coming from folks who are probably work in general practice as opposed to with intellectual folks with intellectual disabilities. And my guess is that they're matching up that little tabular description. But the other thing is, as we make this transition, and we can talk about labeling, et cetera, all day long, but when I think of someone with a moderate intellectual disability, we're talking about somebody who's going to need relatively good support, probably some sort of a supervised living situation. And I don't think of somebody with an IQ in the 70s with that. So I think we're going to have some, as we look at these labels, we're going to have to look real, and the DSM does recommend comprehensive assessment, but I think we're going to have to look pretty closely in terms of what that's, what's involved there. Wide variation in assessment adaptive behavior, already mentioned. That is an issue, and the informants. And in terms of accessing services, borderline intellectual functioning actually still has an importance in the Social Security determination. Doesn't necessarily mean they're going to be allowed, but it is considered a severe impairment from Social Security. Now, maybe some of the rehab folks will. I have not seen anything in the VOC rehab guidelines that suggests there's going to be any change in the guidelines for eligibility at this point. Okay. I also do not see anything in terms of Social Security. Social Security has recently adopted the term intellectual disability instead of mental retardation. There's no indications that they're going to move away from the criteria. And some of you may already be familiar in terms of intellectual disability. You can qualify under a number of criteria. One is where you have an individual who's displaying almost total dependence and on others, and essentially can't be tested. An IQ below 60 has been generally, and I want to make sure I'm not speaking for the entire federal government on this, but has generally been an automatic assessment if the evidence is consistent. In other words, if somebody has a full-scale IQ of 54, they're typically an allowance in terms of Social Security. IQ 60 to 70 with another severe mental or physical impairment. For example, the hypothetical that I said with an IQ in the 60s and major depression, it has to be a severe other impairment. Or if someone had another physical impairment that would be considered severe, that is typically an allowance. And there's some guidelines on what's non-severe and what's severe. And then the 60 to 70 individual with just severe functional deficits. And in terms of measured by adaptive behavior or just other reports. Now, given that Social Security just recently changed to the intellectual disability and they have not come forth with any other guidelines, I foresee in the future that they're still going to be using the numbers, the IQ numbers, as one of the primary criteria. Okay, that's all I have. Questions?
For borderline intellectual functioning, there's no number given now, is that correct?
It's a little paragraph in the back.
No IQ number.
No IQ number. I'm pretty sure the only thing they say is that there may be some difficulty diagnosing borderline intellectual functioning versus mild intellectual disability. And again, I think all of us who, and I think the example you gave in terms of we know folks who are just above that like a 73 and whatever the measure, but clearly function in the intellectual disability area. But there's no number attached to it.
Do you know like how they distinguish between disruptive mood dysregulation order and bipolar in children?
I don't think we have enough experience with that yet. I actually, when I put that up there, I did a little bit of a lit search on that. There are different criteria, and I think when you read, and I think what Ted said is that I think they've tried to sort of describe it in a bipolar-ish way without labeling it as bipolar. And again, one of the differential diagnoses that I see coming through a lot is where the ADHD is mixed in as well. But I haven't seen enough. Matter of fact, in terms of that particular diagnosis, in the kid cases that I've seen come through, I have maybe only seen that in one or two cases so far. So I don't think we know how that's going to get operationalized yet.
Their disruptive mood dysregulation disorder has some features in common with intermittent explosive disorder. I don't know if you've noticed that. And the main piece that I've been able to pull out between those two is that with intermittent explosive disorder, mood should return to normal range in between tantrums or episodes. And I think for disruptive mood dysregulation disorder, mood is supposed to stay primarily
Variable.
irritable or negative all the time. So I've sort of looked at those two, and I don't give bipolar disorder diagnoses for kids, so I just haven't thought about that, and I've sort of focused on those two. I think maybe the intent is that fewer people. I hope that disruptive mood dysregulation disorder could be a term that describes current behavior as opposed to predicting what forever might look like. And I think a lot of people have given bipolar disorder to a child and assumed that that was going to be a continuing condition. So maybe one of the moves here is to say, well, let's see if we can describe what's happening now and wait and see if we get true cycling later or what might be present later.